All right,
Okay.
so our project title identifications of effective biomarkers in predicting the survival of patients with severe sepsis and septic shock. Due to geographical difference, my teammate cannot make it to the presentation, so I will present it on their behalf. Okay, so a little bit on the background. So sepsis is a life-threatening medical condition in which the immune system of the body overreact to the bacterial infection in blood, inducing a cascade of cytokine activations, or more commonly known as the cytokine storm, and result in a wide range of possible symptoms such as low temperature, rapid breathing, or low urine output. Severe sepsis can progress to septic shock, a condition characterized by low blood pressures and organ dysfunction. Despite the advancement in understanding the pathophysiology and the monitoring tools, sepsis and septic shock remain among the most prominent immediate cause of death, with extremely high morbidity and mortality rate, especially in the critically ill patients. And it has been estimated that this condition affects approximately 1.7 million adults and over 250,000 deaths in the United States per year. The outcome of sepsis and septic shock has been shown to benefit from early interventions, leading to an increasing interest in the method of prognosing patients with these conditions. And one of such method is exploring the potential biomarkers, or the definition of biomarkers, like the medical signs that objectively indicate the clinical state of the patients with high specificity and sensitivity. And among all the biomarker for sepsis and septic shock, lactate level has been established as an important measurement for characterizing the severity of sepsis and prognosing the survivability of the patients. Uh, a little bit more backgrounds on the biochem part. Lactate is basically the product of glycolysis under anaerobic conditions without air, with the catalysis effect of lactate dehydrogenase, a type of enzyme during a TCA cycle. In patients with sepsis and septic shock, the blood circulation and respiratory rate decrease, reducing the oxygen level in cell, which eventually lead to an increase in the amount of lactate produced, or also known clinically as hyperlactemia. However, there's contradicting evidence on which time would be the optimal measure for lactate post-diagnosis, as well as there has not been a lot of attention in all the potential biomarker. So what are our goals for this project? We actually have two goals. The first one is to examine the optimal post-diagnosis time for measuring lactate level to serve as a good predictor for the outcome in patient with sepsis or septic shock. And the second goal is to identify all the potential biomarker for sepsis and septic shock prognosis. Moving on to materials and method. So basically, this is a retrospective studies that was conducted in patients over 18 years of age diagnosed with septic or septic shock at the National Hospital of Tropical Disease in Vietnam from June 2018 to July 2022. The criteria for diagnosis proposed by the guideline of the Sepsis 3 and Surviving Sepsis campaign. I will not list this out here because it's kind of technical, and you can see more on my manuscript on the website. Any patients transferred from other hospital has a history of liver or kidney failure or experienced circulatory or respiratory arrest before admission were excluded from the study. On admission to ICU intensive care unit, demographic information and measurement were collected. Lactate level were recorded at time of diagnosis, denoted as T0, 24-hour post-diagnosis, denoted as T1, 48-hour post-diagnosis, denoted as T2, and 72-hour post-diagnosis, denoted as T3. The outcome of each patient, either died or survived, were recorded as well. In terms of data analysis, once the data have been collected, descriptive analysis was performed to understand the study population and identify collinear variables. Because some of the patients might have died before the time point of the 72-hour post-diagnosis or 48-hour post-diagnosis, there are a lot of missing values for lactate levels, and therefore we have to find strategies to fill in the blank. And we derive two new variables, which are the lactate level at peak and its associated time point to improve the assessment of lactate as the predictor. And with all the variables, we use k nearest neighbor to impute the missing value with k equal to 12. So basically, they're using 12 different data points randomly in the data set to fill in the blank. After the data imputations, a random forest model, which is basically a collection of different decision tree with the majority of voting deciding the classification result of the entire model, was applied to find the most suitable variable for prognosing the patients. We actually used the mean decrease in Gini index. So basically, Gini index is the score where the model kind of evaluate the impurity of the tree at a given depth. And we then group those with really high GID or mean Gini index and their clinical values together into a group. And then we use the logistic regressions to evaluate the actual performance of those model. And we also compare those model with the random forest as like a really good standard to see how good the other model are. We do the same things for the lactate level at different time points. So for the results, we actually calculated the mean, the standard deviation, and the range of the 33 variables in 134 patients, as detailed in our manuscript. I didn't really list all of the variables here because, again, I have to explain most of the clinical importance of those variables, which is going to take a lot of time. You can find all of those details in our manuscript on the website. There is an approximately 16% of the missing entries input either through k-nearest neighbor or extrapolations. And due to the questions of our studies, we decided to not focus variables related to demographics of the patients. As you can see here, we have two figures, kind of like a way to describe the data set. So figure one is basically describing the SOFA score or the or sequential organ failure assessment score, with the higher score indicating more severe condition with more dysfunctional organs. And also we have the second figure, which is a spaghetti plot. As you can see here, the one in red is basically those patients who die, and the one in greenish is kind of like those who survive. And as you can see there, most of the patients who die don't really have like the lactate level recorded at the later time point. In terms of the random forest model, we perform a research to kind of make our model stronger. We finally decided on using 2000 decision tree, each containing a maximum of 9 nodes, and each feed using a randomly selected set of 15 candidate variables. And as I've mentioned before, the models, we are using the Gini index decrease, the mean Gini index decrease to evaluate the variables. And the highly important variables were grouped with all the variables of the same clinical significance. So as you can see here, we have like 5 different groups. The first one is the infections, which we basically combine procalcitonin level with C-reactive protein level, immunity, platelet, white blood cell, neutrophil, and lymphocyte. Those are all of the immune cells in your body. We have liver functions, which combine albumin level, aspartate aminotransferase level, and alanine transminase level. And then we have blood functions, include the red blood cell level, the D-dimer, and then the hemoglobin level. And finally, we kind of group all the metabolites within your bodies together and record metabolisms, which combine the urea level, the sodium level, and the potassium level. And then we use stochastic regressions to compare this model together and again with the random forest. These are the GID of some of the important variables. Most of the GIDs range from 0.5 to 1. You can see the procalcitonin level are really high compared to other, and then the peak lactate level as expected. And this is the GID of the lactate levels at different time. Again, as you can see, at the later time point, the GID is much higher. And here we have the ROC curve of the logistic regressions model of different groups. As I mentioned before, the random forest model is the line in pink, which you can see is at the very top for both of the figures. And this is the numbers if you want to see it. So basically, the random forest has the highest AUC value and the accuracy value at 81.34%. And then coming up with the peak lactate level and the procalcitonin level. And in terms of the procalcitonin level and the infection group, it's really surprising to see that the accuracy didn't really improve in a single point. And these are the AUC and the accuracy level of the lactate at different time point. And again, the lactate at the very last time point is really significant and has a high value of accuracy. Okay, for discussion, so what are the key findings of our projects? The first one is the lactate levels can predict the treatment outcome in patient with septic shock or sepsis, as predicted and mentioned in previous literature. And then the lactate level can be a strong predictor when measured closer to the patient's eventual outcome or like at the later time point, as I've shown before. Also, procalcitonin level has a potential to be a good predictor, especially when combined with other biomarker of the same category we expect. There are other indicators of infection level, not only the C-reactive protein. So we can try to do that in future research as well. And future research can also consider to include time of death as a variable to perform either Cox regressions or Kaplan-Meier survival analysis for more robust conclusions. There are a few drawbacks in our project as well. The first one is that there are variations in the measurement of the lactate levels, with most of the available data skewed toward the surviving patients, as has been seen in the spaghetti plot. Um, the second one is regularly monitoring the lactate level can be useful in predicting the outcome rather than focusing on a specific time point, because again, we don't really have a way to kind of balance out the missing data, like even if you design how carefully your study can be. And the last one is the data from National Hospital of Tropical Disease were missing across all variables, which eventually would affect our models and conclusions. And k-nearest neighbor in this case would not be a really good way of imputing the data. So yeah. So we really want to acknowledge the guidance and the assistance of Professor Ryan Miller from Grinnell College on this project. We also appreciate the permission to use the data from Dr. Nguyễn Thị Hiền and Dr. Tạ Thị Diệu Ngân from the National Hospital of Tropical Disease in Hà Nội Medical University. And this study was approved by the Ethical Committee of the Hà Nội Medical University in Vietnam. So yeah, that's the end of the presentation.